unmute myself. Okay. There we go.
Yeah, I'm not
Testing. All right. I think we're good. I think we're live.
Well, sure is.
I'll start with a big thank you for coming. This wasn't easy to set up. There was a lot of bureaucracy when it came to starting a club, but we made it. And MSM Journal Club is here with its first presentation. I'll be presenting alongside Jessica. She's going to be taking the second half. And after that, we'll get to our elections. So just have everybody give a little blurb about who they are, what they want to do, and why they're interested. And then we'll have a little doodle poll. It's not the most professional way to do it. Figured that's a lot easier. And I'll let you guys know from there. We'll make a group chat and get some structure. So my name is Yazan Bucci. I'm a first year. I'm presenting on a drum-related case. I would like to say more now, but I want it to kind of be a mystery that builds up, maybe get your gears rolling and try to guess what's going on behind the scenes. We are recording, so we're good to go. And let me hide this little thing there. Good. Okay. Button. All right, we're going to hold a mouse. So let's meet our patient. Thanks for making it. So AB is a 24-year-old woman presenting to the emergency room. She's presenting with fatigue, fevers, headache, diffuse body aches, a productive cough, and abdominal and lumbar pain. I've listed 4 of her main vitals here. I want to take a quick look at it. Not a lot to work with right now. There's a lot of different conditions that present with this set of symptoms, but move on from here. So who is AB? She is a devout vegan. She is a lifelong musician. She's played the drums since she was very young, and she's part of a band that practices every weekend. And a city festival is coming up, and they're invited to perform. So it's very exciting, big gig for them because they're pretty much amateurs, and this is like the most exposure they've got in their small town. So the performance was a success. The venue was very generous. They actually provided them with their own drums. So they had been working with kind of hand-me-down drums up to this point. So the first time working with something kind of foreign fancy. They used goat skin drums. So that's kind of new. And it was great. She was astonished that she got to play for such a big crowd, considering her experience. And she went home very excited. But that night, or later the next day, her health began to decline. So let's look at some of the findings when she was admitted to the hospital. She got admitted to the hospital, by the way. So I have some lab data here. I just highlighted what's abnormal or relevant to the case, and I'm going to walk through what they mean, the significance of them for us here. So I'll start from the top. You'll see that she has an elevated hematocrit and hemoglobin, and that indicates some hemoconcentration, possibly due to some dehydration and shock. She has elevated white blood cell counts, and that can indicate a severe inflammatory process going on. There's elevated myelocytes and metamyelocytes. That can also indicate systemic inflammatory responses, and we'll get back to this. Elevated D-dimer and decreased platelet counts. So her clotting system is being used over and over again, and she's kind of running out over time, so it's kind of becoming increasingly less effective. And finally, her prothrombin and preprothrombin are elevated, and that's showing us that clotting is slowing down. So that almost a linear increase in that clotting time. Next part, we see that urea nitrogen is up and creatinine. Urea nitrogen and creatinine are up while her GFR is down. So her kidney is kind of tanking. It's not doing a great job filtering. And her increased lactic acid suggests tissue hyperperfusion and elevated anaerobic metabolism. So we're seeing signs of shock here. On third slide. There you go. And last 3, we have elevated lactate dehydrogenase, and that's a marker for severe tissue damage. We have elevated AST and ALT, which also suggests liver failure. And we also see that our PCO2 is slightly increasing, and we can wonder why is this happening. We can circle back to seeing that the kidneys are taking some damage, and you see that the severity of her CO2 differential is furthest out about 7 days in. We know that kidneys aren't very responsive to fixing acid-base imbalances. So you can see that it's kind of catching up to that kidney deficit. All right. So we're going to start with a couple scans. And I tried to organize the evidence with increasing relevance. So as you get closer, it's going to be bigger fish to see. So we're starting with an IV contrast scan, and we're noticing a lot of ascites. And in this case, over the course of her hospitalization, they took out 50 liters of it. There is no bowel dilation, but the thickening of the wall in her small bowel, if you look just below the kidney, working your way down, we see that the wall is thickened, and so the lumen is a little less visible. And if you look at the arrows, they're pointing to some enlarged lymph nodes in her mesentery. Physical findings show that she had some tenderness in a diffuse fashion around her abdomen with normal sounds, and there were many large and avidly enhancing lymph nodes. So we saw those in the CT scan. And the laparotomy revealed 3 liters of ascites. And this is just on the first laparotomy. That 50 liters is them doing it over and over and over again. And lastly, some histology. We have 6 slides. These are all from mesenteric lesions. And just walking through from A to F. A is just the necrotic inflammation of her enteric system. So there's mucosal ulceration and hemorrhage. B shows a higher magnification of it. So we're looking at the same thing. We're able to see abundant neutrophils. So a lot of purple, blue speckling. So that's always an indicator of inflammation. On the third one, C, we're seeing lymph nodes that are indicating hemorrhage and lymphadenitis. And on D is the first time we're going to look at some of the pathogens that are suspected here. So at this point, we're just seeing gram-positive bacilli. That's as specific as we can get for now. On E, we're seeing immunostaining of an antigen, which I will not mention because I realize it's kind of a spoiler, but the red dots are the antigen to this pathogen. And F is the same staining, but used on a lymph node. So we see the pathogen is also inside of the lymph nodes. So let's walk through the diagnostic process. And so this is a quote from the paper itself. The infectious disease specialist was kind of walking through his differential, and he said that 4 clinical features define systemic inflammatory response syndrome, or SIRS: fever, hypothermia, fever or hypothermia, tachycardia, tachypnea, leukocytosis, or leukopenia. And she has 3 of those 4. So we're going to start there. So this is our, that messed up. We're starting with SIRS, and 2 possible routes of thought exist in this differential. There's either PAMPs, or pathogen-associated molecular damage, and then DAMPs is damage-associated molecular pathways. Pathways is the P. So he looked at her history, and he looked at what he was seeing, and she had no history of vasculitides, no history of any vascular disorders, and the onset was very acute in fashion. And so if it was damage associated with no type of trauma, et cetera, then damage-associated molecular pathways were out of consideration. So we knew that we're working with a pathogen. And so between bacterial and viral infections, we had to continue ruling out whether the symptoms that we're seeing are even possibly seen by a virus. And because we were seeing sepsis syndrome, it could not have been a virus. So we're on to bacteria. We have 4 suspected bacteria. One of them presented itself early, Mycobacteria, not in question because she was experiencing hemorrhage, and that's not one of the things that it'll do. But Campylobacter, necrotic bowel, rules it out. It doesn't cause necrotic bowel. Yersinia does not cause ascites. Our patient had ascites. So we're left with anthrax. Now, let's talk about anthrax. It's we're gonna mainly find it. You're gonna see close to the equator in a lot of countries that have a lot of farming-based economies, or just do a lot of bovine farming in general. So Central and South America, Sub-Saharan Africa, Central and Southwestern Asia, Southern Eastern Europe, and the Caribbean. Although I don't think cows are very popular in the Caribbean. And this is just a fun fact. Anthrax is the first time we've ever been able to tie a bacterium to a disease in the first place. And this is the godfather of the vaccine, Pasteur, Louis Pasteur. So, a little quick tidbit about microbiology. This is also called Bacillus anthracis. It's gram-positive, it's rod-shaped, hence the name Bacillus. And it lives dormant in the soil. So it can actually live for decades and decades in the soil in the form of a spore. And until it reaches some sort of biological setting, like moisture, a little bit of warmth, like 37 centigrade, sugar, it's chilling. It's not doing anything. Yeah. Oh, yeah. Thank you for pointing that out. There you go. All right. So on the soil, it's just in defensive mode. It's not doing anything. It's not producing any proteins. It's highly adaptable. You can live in the desert for hundreds of years. And when it gets to these biological settings like I described, it'll activate and begin wreaking havoc that I'll get to. But the good news is, if you have it, you can't actually infect someone else with it yourself. So you can keep your anthrax to yourself. It's nice. There's 4 main ways that you can get anthrax. You can eat it, you can breathe it, and you can touch it, or you can have it mixed in with your heroin. So these are the most common 4 ways. And with regard to the first 3 especially, they kind of subclass anthrax by cutaneous, gastrointestinal, and inhalational anthrax, kind of because they have different branches of symptomology. We'll talk about that in a second, but depending on how it infected you and where it got to first, you're going to see different collections of symptoms, but we're talking gastrointestinal. So when it gets inside, it gets to a biological setting, it begins synthesizing proteins, and it begins synthesizing these 3 proteins: lethal factor, protective antigen, and edema factor. And they're like elements. You combine them, and they make 2 main toxins. So protective antigen is common between the 2 toxin formation, but we have lethal toxin, which combines with lethal factor, and edema toxin, which combines protective antigen with edema factor. So nice naming there. When you put all three of these together, they can attach to what's called an anthrax receptor on cells. Sometimes you might wonder, why do our cells have receptors for things that are bad? So I did some digging, and I found that it shares a lot of the primary structure with the von Willebrand factor receptor, and so that it hooks up to it, forms a pore, that pore endocytoses, so endocytotes, and then it enters the cytosol and begins producing more of these toxins. And so this is kind of what it'll look like in the clinic. On the skin, we'll see gelatinous edema, some congestion and necrosis. This is a very characteristic ring. I think this is seen often, this is the exact image on STEP. It's one of the differentials for dermatologists looking through what happened to a patient that has shared that they've recently traveled. Here are some of the oral or gastrointestinal formations. We're going to see diarrhea, painful swallowing, bloody vomiting. There are way more symptoms that I'm showing here, but these are the 3 most characteristic ones before you get to things that, like, okay, a lot of things cause shortness of breath, et cetera, like listed here. And that's a monkey lung. It's not a human lung, but that's all I could find for a picture of an anthrax lung. So, but it would be black. Not good. So how did AB get treated? Carefully, yes. So leading up to her diagnosis, they already had her on vancomycin and meropenem. So they kind of had to start broad. And when she was diagnosed, they added Cipro. On day 14, the CDC came in and they were able to bring an IVIG. And they made this intravenous immunoglobulin by gathering samples from humans that were vaccinated with anthrax. So they kind of had to cook it up. So they administered that. She continued to get it. 14 days, enough for the vanc and marrow cycle to end. She was only on ciprofloxacin. And about that point, they had to adjust for some side effects because she was starting to kind of get more harm than benefit. And so they switched her to just doxycycline. This is 60 days in. So she was hospitalized for about 2 months. And so there's one thing that I mentioned that's very contradictory about what she got infected with and what the deal with her is. So if we go all the way back to one fun fact about her, actually, we'll talk about anthrax itself. Anthrax is found in bovine animals. We see it in goats and cows and a lot of animals. But something pretty uncharacteristic is the fact that AB is vegan. So how did she get anthrax, especially gastrointestinal anthrax? That's kind of crazy. Well, it turns out the drums that they imported were actually infected with anthrax. And at this event, sorry, I really should have, I meant to ask you guys to raise your hands and guess. So sorry about that. These were goat skin drums. So these fancy drums caused 12 people at this event to contract anthrax. It was like one of the highest concentration of anthrax patients we've had since, I think, 2001 bioterrorism attempts, where I think 11 people got anthrax. That was crazy. And so it was kind of a curveball because it really challenged the clinicians to look beyond the history that she was provided and avoid starkly ruling things out. So it kind of highlights the benefit of considering all possibilities and considering beyond what's on a chart and what's measurable with numbers. So they found this out by getting a little bit deeper into what AB was doing that weekend. They found out that she was at a drumming or a concert that she was playing for. It matched up with the bacterium, and they found out that's the only possible way she could have been exposed to it. She's super vegan. So that was her treatment regimen. She went to rehab afterwards, I think for about 18 days. She had lost a lot of energy and muscle mass. She was very weak after. So it was pretty devastating to sit through. So that was the recap I just mentioned. These are my references. All right. Jessica, you want to go? All right. So let me get this microphone set up for you. And I'll switch the presentation here.
Yazan.
Yeah.
I had a quick question about if you.
Absolutely.
I know you said that it's not transferable from person to person, right?
Yes.
Whenever you mentioned like the ways that it's transferred, you said that one of the ways was through the air. Is there like not a way people can?
The spore itself. And so despite all the things that it does in the body, one thing that it doesn't do is create anything that would be released through ducts or, I mean, unless you like the fourth way that you get infected was IV drug usage.
That makes sense.
And that would be like the case for a lot of things that aren't traditionally contagious.
Yeah.
But in terms of actually creating a vector outside of sharing blood, you're pretty safe there.
That makes sense.
And click the on button.
Hello. Okay. All right. Good evening, everybody. Thank you for joining. So what I'm going to be talking about is caregiver quality of life today. I got a little interested in this when I took Dr. Green's course last year in deaf and hard of hearing. That was really interesting to me. So I started getting a little bit more interested in ENT. I reached out to a PI at Mayo Clinic Jacksonville, and we collaborated. And now we're going to be doing this huge systematic review that's going to take up a whole lot of my time, but it's going to be great for science. So first of all, let's talk about age-related hearing loss. I'm pretty sure a majority of you have somebody who's a little bit older in your life, and you have to speak a little bit louder. 1 in 3 people over the age of 65 experience gradual hearing loss, and sometimes it gets to the point where they have a negative impact on their communication, their mental health, as well as their quality of life. So majority of people who are over the age of 65 and weren't born deaf probably aren't going to learn sign language. They may use a hearing aid if it's not that bad, but another option is to get a cochlear implant. It may be a little scary to give a cochlear implant to somebody who's a little bit older, but it's safe and effective, so let's move forward. So the paper I have been looking at initially is Caregiver Quality of Life after cochlear implementation in older adults. They took people who were the age of 65 and received a cochlear implant between 2000 and 2019. And then they sent them a bunch of surveys. So one of the surveys was the significant other scale for hearing disability. And they asked their caregivers to take the survey. So the patient didn't have to do anything. Another few variables that they considered outside of the survey were the caregiver role, patient gender, frailty, which is really just how many comorbidities they have, duration of hearing loss, if they've ever used a hearing aid, and time since surgery, and if they improved after the surgery. So quick results, 71 caregivers completed the survey, and they sent out maybe like 250. So this is kind of a sad turnout, but that is life with surveys. Maybe like 75% of them were a spouse or significant other, 17% were a child, and 5% were other, non-disclosed. And they found that gender and frailty of the patient was associated with the caregiver quality of life, but the hearing outcomes weren't. So that was a little bit interesting. So, okay, it ended up being a little bit bigger on here, which is nice, but I'll still orient you for the people in the back who can't really see. So this is the survey results. They looked at communication changes up at the top in red, communicative burden, relationship changes, going out and socializing, emotional reactions, and concern for their partner. And then over here at the bottom in gray is the overall caregiver of quality life. At the top left, you have whether or not one of those categories was a big problem, like a complete problem. And then over at the right is whether it was not a problem at all. And if they didn't think it was a problem, they got a score of 100. If it was a complete problem, a score of 0. So overall, in yellow, we see that the relationship changes wasn't really a huge problem for these caregivers, but the communication was a pretty big problem. And overall, they're moderately to mildly concerned about their quality of life. So in conclusion, the caregivers of female patients who didn't have many comorbidities had a better quality of life. So what does this mean for overall patient care? Obviously, we all know that gender plays a pretty big role in our patient care, but most people don't really consider frailty. They think of like age. You know, you don't want to give surgery to somebody who's 80-something, but if they don't have many comorbidities, they may benefit from the surgery. So that is something to consider when you're going into your patient care areas or if you're doing research on patient care. So next steps. They would like to assess the Speech Recognition Association with quality of life. And they mentioned that they had assessments, but it wasn't standardized across the board. So they're gonna have to look at that because it doesn't make sense that if you improved in hearing, your caregiver quality of life would probably improve as well. So they're gonna look at that some more. I think they should include some variables on economic statistics because cochlear implants are expensive. So if you have more money, you might have a better quality of life. Or if your insurance wasn't paying for it, then maybe you have a poor quality of life. Who knows? So that is something to look at. Another limitation was that they didn't look at the preoperative surveys because they didn't have them. So we're not really sure if pre and post-operatively the quality of life was better or worse. And lastly, I think we should all develop a pretty broad caregiver quality of life survey. This one was only for spouses and significant others. And they tweaked it a little bit so that they can include the children and other people, but that's not what the survey was designed for. And it's pretty important that we look at caregivers because even though they're not your patient, they're still taking care of your patient. And if their burden is so high that they're becoming disabled because they're taking care of the patient, now you have another patient on your hands. So it is something to consider as we continue giving better patient care. That's me. Wait, I'm not done. Shameless plug. I am in the ENT interest group. So if you want to learn more about ENT, specifically about facial plastics, please join us March 25th. It's on Zoom. You don't have to go anywhere. You just click on Zoom. And now I'm done. Yeah, go ahead.
I have a question kind of about the next steps you were talking about.
For sure.
So one of the things that I think could be interesting as like a next step is comparing like caregiver for older people, but also for like younger people that get implanted as children. I'm curious how that kind of compares as far as like a parent taking care of a child that gets implanted versus, I don't know if that makes sense.
Yeah, for sure. There's actually quite a few studies that do that. So as I'm working on the systematic review, I'll let y'all know
Yeah.
what I find.
Really cool.
Thank you for that.